Hi, thank you so much for joining again our podcast, Take One Patient, where we talk about patient communication and meet with experts in the field in this space. My name is Julie Soukup. I work with medical memory, and I'm very excited to talk to Dr. Dennis Liotta. He's really here with a background in independent living, transitions of care, and all these things. But why don't you start by actually introducing yourself, a little bit of your background, and kind of where your journey has kind of gotten you to in the medical space.
Okay, so basically, all of that could come under the heading of long-term care. I've been in this space for a number of years. I've been a physician for over 40 years, internist, and also did a fellowship in age management medicine. And so I got involved on the managed care side about 30 some odd years ago. A little bit longer than that. Yeah, probably 35 years ago. And My forte really was the involvement of both commercial and government programs, but I really took on the role of really getting into the government space, which means Medicare and Medicaid. And that really is a major part of what is out there in the managed care environment. We tend not to believe that our country is, believes in socialized medicine, but Medicare and Medicaid are social programs. The VA benefit is social programming. There are other also benefits that are associated with social benefits, meaning that there's greater than 50, close to 60% of the population that is in a government program, meaning that we have a socialized medicine plan in the majority. So hard to believe, right? And we keep fighting over this over, like 40% of the population. So, but in that whole learning process, I was involved in being one of the, being part of a health plan back in the late 1990s when the uh, Part C, Medicare Part C Act came into being to be in a health plan that was one of the 15 uh, plans to actually get a contract with CMS for the Part C program. And for those people who don't understand what the Part C is, don't know about it, that's a, um, a health plan that's a commercial health plan that submits its application to CMS in order to get a contract to do Medicare work. Right now, and you see, and people don't realize sometimes that Aetna, Humana, United Healthcare, all of these companies out there that talk about Medicare and, get your Medicare, they do the enrollment between October and December of every year, and they're always looking for people to get in. That's Medicare Part C, and they cover original Part A and B, and they also cover Part D. They usually are anywhere from no deductible, no co-insurance, no anything, to other plans that have deductibles and have co-insurances and things along those lines. People, seek the best benefit out. Now, a lot of people sit there and say, "Oh, like I don't want to go into a Part C plan because I lose a lot of my freedom that I have in a Medicare a standard plan, where I just getting it from fee-for-service Medicare or original Medicare." So the background there, that's just my husband walking by. And we both work from home. And so, people don't understand that you can find the right plan that's suitable for you, and really limit down the cost exposure to you. So, where does all this come in, and why should you know about all of these different things? Is because it's really important that if you are sick, do have needs, special kinds of needs. A Part C program could really be of added benefit to you over having just a standard Medicare plan, because the Part C plan can help you in order to define certain things and what you need, and then also look if you qualify for other services that are outside of the scope of Medicare, which could mean just benefits that are in your community as part of a county or state benefit, or even going as far as saying that you qualify to have Medicaid as a supplement to your Medicare, and then also your eligibility if you are a candidate for long-term care services and supports under the 1915C waiver program that supply both home and community-based services as well as nursing home benefits as well too under that program for those that have more extensive needs. So that's what I've been focused on for the last umpteen number of years, and it's not an easy thing. A lot of people think that it is an easy thing. It's not. When you get involved with the government on anything, and that's why I think a lot of people don't seem to like government healthcare. Is there are a lot of uh, things that you have to know about. But the wonderful thing that I have found out about all these years really is that the government is very consistent. So if you know these certain things and you learn about them, they will be consistent for years to come. The government really doesn't change very much. So that's the one thing that I really like about government programs is that they are consistent. Commercial programs aren't consistent because they go with the flow of the people that are buying them. And so if people want this or they want that, if they want nothing, it kind of changes. With the government,
Yeah.
and especially more so with Medicare than it is Medicaid.
So and correct me if I'm wrong, because even in our communication, this is a lot that I had learned about it, and a lot was it because I didn't qualify for more for them. But even having my parents that are now aging and going through spine surgery and health challenges, how are a lot of these like patients that now qualify for Medicaid and qualify for these programs, like how are they educated about what they should or shouldn't be doing, or is it just their responsibility, the hospital's responsibility? I mean, what kind of mechanisms are used to communicate in those aspects?
Well, the first thing that I'll tell you is don't ask your doctor, okay? Because they have no clue, none whatsoever.
Okay.
Go into any office and they have no clue, okay? They will refer you out to a social worker or something, or even the hospital sometimes.
Sure.
Hospitals are supposed to be well versed on on all of this, as being one of those transitions of care places. So they are much better at it. The best thing to do, I tell people, is to call, your local um, Department of Elderly Affairs that would be in your community or in the state to give you more information. On it. There are, the agencies for the elderly and aging, usually that go by county in just about every state. Some counties join forces together and come together in order to address these needs because they may be in rural settings versus in urban settings. So that's where you really need to go because you do need help on all of this. This is not going to come magically to you unless you are in the hospital and you're just in bad shape and you have your Medicare and you're laying in the bed and there's no family around or whatever. A social worker comes in, they figure out all these different things, and that's the person that is the squeaky wheel that gets the grease. Everybody else is out there on their own. Okay. And the other thing that is very, very important for people to understand, and I get this question a lot from people, and is that the Medicaid program, the long-term care program around the country as part of the waiver program are all income based. Okay, so you have to be at the poverty level or below in order to qualify. If you are above $1 above, okay, you don't qualify. All right, that's it. And so, where do you go for services? And a lot of people will sit there and say, "Well, I don't know. I've worked all these years. I don't understand. This guy down the street is getting services, but I'm not getting any services. And it's just based on the fact that he or she's got no money and I've got $15 more a month coming in. I
Yeah.
mean,
Yeah.
how just is that? I, you know, I've been fighting this whole thing for many years and sitting there and saying that the waiver program does not serve the state very, very well. But the problem with the waiver program is that it's limited. It goes state by state, unlike Medicare. Medicaid is a state run, in association with Medicare, is state run. And every state has a different level of the 1915C waiver program for long term care, or any of its programs are separate and distinct. They can have some similarities, but they're not the same. Some states, are they have the ability to have 5, 6, 2,000 people in their long-term care program. Here in Florida, in the state that I am in, there's only 120 people that are allowed in the program in any year. Okay, and there are about 70,000 people on the waiting list, and the waiting list grows every year.
Mm,
So people are literally dying to get, in order to get in, they have to wait for somebody to die in order to come in.
sure.
There, so that's very, very, very problematic. And we really have to understand, because with the growing population, especially with the boomers coming into this and growing very fast, okay, it's going to take, what do you do with people who, make over that poverty but need help? What do you do with them? Because those people reflect a significant cost going into the Medicare system by going into the hospital
Mhm.
because they don't have anybody in the home setting in order to take care of them. They can't
Sure.
afford it,
Yeah.
right? So what do we do? So that's where the community services. Now again, that's only going to service a very, very small percentage of the population. Um, but families need to get together and help their family members, because if you're waiting on the government in order to do that, you're waiting for Medicare to do that, it's not going to come on.
Sure.
Medicare has been resistant in doing this for a very, very long time. But we need services, and services like what you provide in medical memory is really something that you know can help people. And if it's affordable, and any of these programs, if it's affordable, people will do what they can, uh, in order to, make it happen. Families,
Yeah.
will get together. But there's nothing else that you can do. You can't get the government to make these
Sure.
payments or to do anything else, unless people in advocacy groups go back to the government and start advocating and lobbying to state legislators.
Sure. Well, and I think that's one of the interesting things that we spoke about with this, and I'd love to hear more also about. You were talking a little bit about the Advanced Directive Act and how that's communicated, and so I have two kind of questions with this. First is, definitely as you spoke about, I think one of the powers in medical memory, the tool that we use, where you can record, that social worker coming in and talking to that patient, you can record some of these things in hope that you're getting some collaboration, some family, some support around these patients who they might not understand. Maybe someone in their family understands, or at least this is a way to be an advocate for the patient to be able to communicate more eloquently about it. But with that, you were saying, the caseworker comes in, the squeaky wheel gets the grease. So where are you said the doctors don't know, but where is the responsibility of a hospital or of anyone to kind of educate a patient about these things that are available? Is it just a social worker, or even the things that they have to, which is one of the things you were talking to me about, was that advanced directive law where they have to make sure that all these patients have at least this, and that's mandatory, but not explaining the other things. So how, whose responsibility is that, and where can that communication be bridged, if you will?
Technically, it's supposed to be in the primary care provider's office, or it should be in every office, because every provider is a point in transitions of care. But it should be in the primary care office. But they're not well educated on it at all. A lot of people don't even know, uh, about certain pieces of legislation that are out there that they're responsible for, and that's because there has been no penalty that's associated with people who are non-compliant, right? So, one of those things, uh, is the Patient Self-Administration Act, okay, which sits there and says every patient is uh, is in need of information coming from their primary care provider or any transition point where things are absent. And in this particular case, it speaks directly to the advanced directive. And the advanced directives are all of those things that are talking about, uh, your living will, and, determinations that if you are incapacitated physically, mentally, both, who's going to step in for you and all that other kind of stuff are really is really very, very important. Now, Medicare, the CMS, uh, you know, said that they did not want to be responsible for this. This was not in their bailiwick in order to do. So Congress enacted and sat there and said, well, everybody else involved except Medicare, okay, will be responsible. So the doctor's office will be responsible, hospitals will be responsible, Part C plans will be responsible. Um, Hospice agencies, long-term care facilities, just about everybody you can think of is responsible, okay, for educating people on the advanced directive and other things that they need, to have in uh, their medical record. But that doesn't go on. And uh, I sometimes ask doctors and said, are you talking to people about their advanced directive as part of your intake at any time? Does your staff do it or anything like that? And they look at me like I am speaking some foreign language. Okay. Then when I show them the documents and say, did you know about this? And they, no. Okay. But you're a large group practice. You bring in $30 million a year. You did not know this? No, we did not know this.
Yeah.
Okay. And hospitals do the same thing. Hospitals will ask everybody, do you have a living will? No. Okay. They'll check off the box. No, that's it. But the act says they have to give them information about that and try to get them to sign off on it, right? So that they can actually do it. Because it's very important. Okay,
Yeah.
because if somebody comes into the hospital unconscious, okay, they have to do whatever they can in order to do the best for that particular patient. And then if they call a relative and they say, well, we need to do this or this or this, or they need to go into, rehab, or they need to do this, but they're not cognitively available, right? The hospital can't ask the son, the daughter, or anybody else, because the person never signed anything. So
Yeah.
that means that the son or the daughter has to go and has to go to court and get the documents,
Yeah.
okay, as part of emergency standard. Now hospitals can do that as well too, and to be proxy for that person, okay, and act as proxy for that person in certain situations, not in all situations. So
Yeah.
it's very difficult. So hospitals are the leading ones that go after that kind of advanced directive.
That
But the one
part.
thing I can tell you about hospitals, I'll take this one, 30 seconds here, is I would love if the hospitals could record on the discharge planning, okay, their people giving the discharge planning information, okay, where it's on a recording. They can, they go online, boom, the son, the daughter, the cousin, the neighbor, whoever can go and listen to it, because a lot of the time the document, the discharge sheet, okay, may have gone via email to the doctor, to their PCP, but the doctor doesn't read it to 3 weeks later, and the family doesn't know. So what medications you're on, what do you got here, what do you got there, what do you got the other thing, and try and get that discharge planner to call you back, okay? Because mom, dad, Aunt Esther, you know,
Yeah.
they lost the document between the
Yeah.
hospital and going home.
Yeah. Well, and that's one of the things, some of our top hospitals, they are doing that right now and they're recording that. But even going to your previous point, is a lot of these hospitals will actually pre-record a lot of this information that gets sent with every patient. So any patient that even would go through the process, get the discharge, they'd automatically get another video from the hospital that could include this bit of information, and in hopes so that of course, what's in it for me as a hospital? Well, now I'm not going to get my fines or whatever it is by not having it. But it's such an easy thing to educate and automate with like 2 clicks to all of your patients in a mechanism they can understand, which is the power of video, so that they have it,
Yeah.
they can share it. The paperwork, the reading, it's one person has it, no one can support them. And I think that's what we're starting to see, just as you said in that discharge. But it's a lot of it. Well, what are these other pieces of education that we have to have, recorded? We have to make sure that these patients have the information. How can we just make it be, well, click, click, go? Every patient now has it. Now, is the advanced directive law, was that the first time that patient education in some aspect was mandated meaning, the hospital gets fined? Is that right? Is that the first time
Well,
that a piece of
yeah, but
education has been mandated?
it never happens. Okay,
Okay.
it never happens. All right. Hospitals will have, like I said, on the intake sheet, they will have yes or no and a lot of other kind of stuff, and they will minimally follow it. But they don't aggressively look to follow it unless they're in a precarious situation where they don't know where to move next, or in the care and treatment of that person, uh, that has any kind of urgent or emergent needs, or in their discharge. Okay,
Okay.
and where they got to get the person out of the bed. All right. And so that's when everything kind of comes to full steam ahead. Let's do this. Where's the next of kin? Let's get, let them go to court. Let them do this, whatever it is, they're going to look to get that person out, because, you know, they've already sent out the notice, uh, via Medicare, that the person needs to vacate that bed. And if that person
Mhm.
doesn't vacate that bed, they're going to get charged for each day that they're there, right? So there are penalties to the patient. There are penalties in a different manner to the hospital for not moving that person out as expeditiously as possible. So
Okay.
there's a lot of things here. So the system is broken in many places, and all you've got is gorilla glue and duct tape holding it all together, pretty
Sure.
much.
Sure. And that's, I think, where everyone's saying like educate, 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 and it's like, okay, great, let's make another flyer, like let's make another here's another packet. And I think that's one of the things that we are really advocating for is, well, how do we not just educate this patient, but their continuum of care? Everyone's getting older. My generation is probably one of the first that's really, really needing to take care of their parents and their kids, at the same time, and has the means and education to do so, and so I think it's becoming more, well, I'll do whatever it is if I know what's going on, and I can't always be there, so
Mm.
I think it's
Right.
becoming an interesting place. Well, a lot of these pieces can get, automated, these information, even just these are your options for transitions of care. You could go here or here or here. This is what it's going to look like. This is what all of those pieces would help improve streamlining that without making it, record every time. It's like, here's information for everybody in our facility that's in this genre, that makes it trackable, shareable to family, and really
Well,
simple. So
what I'd like to see is, I'd like to see, like, in every, the offices today, they've got the video screens, in their waiting room, the video screens in their actual exam rooms, where people are ushered in from the waiting room into the exam room, and then wait, another 3 days there before the doctor or whoever is going to come in to see them. And so while in there, they can easily just put on a video that sits there and talks about the advanced directives, right? So like your company would sit there and say, here's a series of videos about the advanced directive and the need for the advanced directive, and play it for the people, right? When they see it enough times, every time they go into the office, okay, they may turn around and start to ask questions. Or when either uh, the aide comes in, the medical assistant comes in, did you watch the video? Yes, I watched the video. That's the 14th time I watched the video, and okay, all right. So I guess I really need to do this, right?
Yeah.
Because sooner or later it's going to sink in,
Yeah.
right? Right.
Yeah.
And
And that's a
and
little bit of that power too, is okay, well, maybe my kid knows how to do it. Can you share it with her? Great. Now I'm also accountable to you to make sure that we're taking care of these things that I wouldn't even know were needed. Or just as you said, what if, someone's in my unconscious, somewhere they don't even know where we are, like all those pieces that should be lined up so that they are being cared for in the right and proper way that we would want. And I think that some of it is, as you're saying, baby boomers are getting older, their kids, their family, they want to support them, they want to help the healthcare burden, but also don't know always all of the things and the resources, and can't be there for the 10 minutes the case worker is walking by. So, or every appointment. So I think a lot of these things go beyond just here's the information about your specific case, but here's information about, healthcare and what you're accountable to
yes,
and eligible for across the board. So
right, right, right.
awesome. Well, thank you so much. I so enjoyed our conversation. I so enjoyed our first conversation where I learned a lot of these spaces and did not understand it at all. And I've been in medical sales forever. And I was like, wait a minute, I don't even know these things. So I appreciate the new perspective and a lot of the things to start looking and digging into, just, to be more effective in communicating and educating and supporting, the patients, whether through the funded programs or not. Incredibly important. So I appreciate your time. Is there anything else that you'd like to add?
No, I just wanted to, because I'm an advocate here, definitely for the elderly, because I think that a lot of people have gotten the short end of the stick, so to speak. And I really want people to go and understand their Medicare rights, understand what they're entitled to. No matter what your health plan says, there's always more. There's always something else that you can do. If you get denied for something, you have the right to appeal. I'd like to make sure that people, if they need services, are active out there in their, calling their community, the Department of Health, the State Department of Elder Affairs, the, um, the Department of Children and Families, uh, depending on which state you live in. I really think that this is so important because so many people are in need, and there are things out there for them, and that they should not have to uh, suffer or go without if there is something out there for them. There's not going to be out there for everyone, but unfortunately, we don't live in a society like that. But if we can help, one, two, three, every week, then we're doing something.
For sure. No, I appreciate that. Awesome. Well, thank you so much for joining us. And we look forward to hearing more maybe from you down the road.
Thank you so much. I appreciate it, Julie.
Thank you.